Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Well, I'm super excited to chat about this. Thanks for the invite. I think my interest in this originally came from working with the ATC and being asked to do some talks, and certainly, down in Vancouver, we see a lot of folks using meth. And so it's been a special interest of mine. I just sat for the addiction boards. We'll see if I passed or not in a couple of months. But anyway, happy to share all this stuff. And I know you all also heard a talk on methamphetamines and psychosis recently, so hopefully I won't overlap too much with that. I don't think I will. Disclosures, really no conflict of interest. I will discuss some non-FDA approved treatments. There aren't any, but there are some treatments that still can be effective. And usual disclaimers here, and we'll move through. So the objectives, really, I'm going to start with just clarifying the epidemiology of methamphetamines and HIV. We'll discuss some of the evidence-based interventions in terms of behavioral care, non-pharmacologic stuff, and then as well talk about the different meds and the data that's been tried for helping folks with methamphetamine use disorder. And I would say really I think the first thing, probably most importantly about all this stuff is it's hard. Like methamphetamines can cause a lot of chaos. And so it's challenging work. I love this picture. This is from tweaker.org, and it's probably my favorite science website. It's put together by men who have sex with men who had used methamphetamines, and it's really quite funny. And it's great for patients, and it's also just good information for providers as well. So a couple real basics. We won't talk about this in detail at all, but meth, of course, activates the sympathetic nervous system, the fight or flight. It releases a ton of dopamine, as well as some serotonin and norepi, and it's very neurotoxic. In terms of how it affects the body, I think of it affects lots of organs we'll discuss, but the two main ones I would say is really the nervous system with psychosis. And again, this is up to, over a quarter in heavy users. So that is a lot. And then we'll talk a little bit more about the increased impulsivity and some of the behavior things that also derive from the effects of meth in the brain. And then we see a lot of vascular toxicity as well. So cardiomyopathy, MIs, arrhythmias. This is a very toxic drug, probably at least twice as toxic as tobacco. So I think it's just worth being aware that this is where most of this runs into. Of course, there's the stuff that we also think about, sometimes meth mouth with the decreased saliva, increased acidity. You can have really pretty rotten teeth at times. And of course, you can run into some acute kidney injury, rhabdo, and then in the gut. Commonly people will experience some decreased thirst and hunger in particular, which plays into, as we're talking about, kind of harm reduction and stuff. And occasionally we can even see gut ischemia. And then the last, I would say, patients will talk about this. They have an increased sex drive, but sometimes a delayed orgasm. Sometimes it's even referred to as crystal dick. So that can be, the interplay between meth and sex can be very challenging, as you all know. I want to talk very briefly just about the evolution of where meth comes from and how it's changed. And for those of you who remember Breaking Bad, they actually did a nice couple episodes talking about how this has changed. It was originally produced from ephedra, so Sudafed, and then after kind of even before Sudafed started getting tighter in terms of control, people started going to a technique called a P2P or phenyl 2-propanone. And that was originally seen in the 80s, but in pretty small amounts. But by 2003, we were really seeing a lot more of this methamphetamines in the Northwest from Mexico. I did a talk to another HIV group, HIV workforce group with a patient. And I have this bit of slide in here because that's when around the time he had been using meth prior to that, but he really started to notice more psychosis. And that's actually, in his case, something that persisted. And so, I think in many cases, that probably was the meth that sort of triggered that. By 2012, really most meth in the U.S. is made with this. And then increasing the potency, the enantiomers are now separated. They figured out many of the tricks that we use in pharmacology. And so many are associating this newer meth with increased rates of psychosis as well. There's a really nice article. For those of you guys who haven't read it, it's very readable and just delightful. It's in The Atlantic. It was attached in the email by Sam Quinalones, talking about, and the top of the article is just, I don't even know if I'll call it meth anymore, and just talking about how, in his sense, sort of how that change of methamphetamines has really affected many things, including homelessness, etc. The other thing that I read that was really kind of fun to read, I don't often read things from the DEA, but the National Drug Threat Assessment is pretty fascinating. It's lots of nice pictures and very well done, and so they comment that meth continues to have very high purity, potency, and very high availability. They mentioned even, I think that they estimated there were 2 years worth of inventory to supply the U.S. should they not be producing anymore. So massive amounts. Some basic stats. In 2019, 2 million folks in the U.S. used methamphetamines. And you can see from this graph here, certainly opiates have gone up tremendously, as we all know, but psychostimulants have as well. And especially from 2014 to 2018, it's certainly gone up since. We're seeing increased use to the ER, and this is excluding multiple drugs, so fentanyl really doesn't play a role in this. So very problematic. Of the folks who are using, about 55% of chronic users have substance use disorder, which is a really high percentage. So most drugs are significantly lower than that. And of the folks who use, most smoke, and about 20% inject. So in terms of what's happening and sort of what are the effects, so certainly we're seeing more and more overdoses. You can see from the graphs here that some of this does certainly have to do with fentanyl being sometimes in the methamphetamine supply. I just heard a speaker who's done a number of research on meth, and he was estimating in San Francisco, his best guess was that about 25% of fatal overdoses where methamphetamine was involved also had fentanyl, and that basically 1 in 4 of those folks, it appeared, the best they could estimate, which is hard, that fentanyl was unintentional. So certainly we're seeing an increase in overdose and deaths from that. I think the other thing that's worth thinking about when you look at graphs like this is what are all the deaths that methamphetamine is involved with that we're not really seeing. And so all the traumatic deaths, for example, someone uses methamphetamines and walks across the street and gets hit, that may not necessarily be labeled an overdose death. Or somebody who has bad coronary artery disease, it's made worse by the methamphetamines and they have an arrhythmia and die when they're not using meth. That's not going to be recorded as well. So I think there's a lot that we're missing in terms of how it's really affecting us. Certainly we're seeing more on the West Coast, but the East Coast is starting to catch up as well. So this is an interesting slide that I wanted to talk about a little bit. That, of course, you guys all know that methamphetamines increase the risk of acquiring HIV for men who have sex with men. And various studies have estimated that's between 15 and 30% that meth plays a role in making HIV more likely to get, which is a lot. And of course, in terms of mechanisms for that, so one mechanism is chemsex, so people using drugs and sex at the same time, so certainly associated with less barriers, more partners, as you know, and potentially certainly can see more skin and mucosal breakdown as well. In terms of how meth affects HIV, I think we all certainly know that, just the effects of meth on the brain, increasing chaos in people's lives, can make adherence to antiretrovirals very challenging. But I think there's also some mechanisms going on as well that where meth acts directly on the immune system. So this McCurr and Siborowski article was kind of a fun rabbit hole to run down. And they looked at some of the basic research, some studies, giving methamphetamines to animals or macaques. And in particular, T cells, when exposed to methamphetamines, and you have an increase in these inflammatory cytokines, you have more oxidative stress, and so you have a lot more HIV replication that happens in the T cells. It's a pretty marked effect. Natural killer cells also don't work as well, and then similarly, the macrophages and dendritic cells are challenged as well, and likely B cells as well. So kind of interesting, and I certainly have one patient who has struggled with adherence, but at times he's been pretty good with that. I do think that this may play a role, and we've talked about that because it's like, I can only tell him to take his meds so many times. It's like he says he's taking them, and so it's nice to at least have a slightly different conversation. couple things I think worth talking about as you think about methamphetamines is one of my goals in discussing this with patients and just discussing it about ourselves. It's less sort of, this is your brain on drugs, for those of you old enough to remember that, kind of fear-based messaging, and more trying to give some folks some understanding of what can happen when you stop using and where you can go. So certainly we know psychosis is common. We know that meth really affects memory, the executive function, processing speed. I think these things are important to remember as you're talking to folks who have used meth or are chronic users, because these things are going to be slower. Auditory memory is especially poor, so I tend to try to write things down more. And then delayed depression, oh boy, this is super common and really worth addressing and making sense of. And I think it's just worth saying that both the brain function and the mood really can improve significantly with time away from meth. And there's a number of functional MRI studies showing this as well. I was actually talking to a patient today, going over some labs, and who really struggled with methamphetamines for the longest time, and he's just doing great now. So it's like you see these people who make incredible strides and put it behind them, but it's hard and it takes time. I also want to call out the SAMHSA article. If you're just going to read one thing, I think this is a really nice place to start, and has some really nice kind of evidence-based stuff put together around a lot of this stuff. So harm reduction, I'm not going to discuss very much, only to say that I think in terms of discussing behavioral techniques, it's a really nice place to start. You can talk about this whether you're talking about injection practices, getting people to try to smoke rather than inject. One of the practices they use in San Francisco is giving people chill packs to, because psychosis is so common, right? So giving them, some olanzapine, 5 milligrams, a couple pills, at the harm reduction, the needle exchanges center. So this principle, of course, applies to any concept, really, whether you're talking about sex. Frankly, I just find harm reduction, even in terms of diabetes, right? Like, accepting people with where they're at and then moving on from there, super helpful. Probably the best data, though, on behavioral techniques in terms of working for methamphetamines is contingency management. So contingency management, that's giving rewards or having some sort of incentive for stimulus control. So if you have a patient who uses methamphetamines, and a contingency management program would say, hey, you know what? If you give me a negative urine drug screen tomorrow, I'm going to give you either money, or more commonly, they give them gift cards. And there's different ways of doing this. And it's incredibly effective. I mean, rewards really work. And the great thing is now it's reimbursed by CMS. And in fact, the SAMHSA article that I quoted actually called out Washington to say that insurances will pay $75 per patient to do this work. Because I think that's been one of the challenges. It's like, well, how do I get the money and where does it come from? And so the insurances can do that. I would say it's most commonly done in drug and alcohol treatment centers. I work at a permanent supportive housing environment. We certainly do contingency management there, and it's less commonly done in clinics, but I think it's something that certainly could be. The data here won't go into detail, but just to say that the measure of the effect size, so P basically determines how is there an effect or not, and D determines the effect size, and there's a pretty good size effect size in terms of this. So behavioral pearls, like we talked about, the harm reduction can be helpful. Brief motivation and interviewing can definitely reduce sex behaviors in people using meth. And then cognitive behavioral therapy is also helpful. And of course, you can combine these with meds. And this is a picture of a wheel, one way of sort of doling out rewards that has been effective with patients. Last, so talking about the medicines, a lot's been tried, and there's the best data for the Mirtazapine and the bupropion, which we'll discuss. Some of the others have also been shown to be effective in fairly small studies. And in terms of the bupropion, this is a data from Colfax. There's a couple of other studies as well. They're small studies. This was a N of 60, but the Mirtazapine did help, and this was at 30 milligrams per day. So definitely something worth considering and something I often offer to patients. Many patients also have coexisting either insomnia or depression, and so it can be a very useful thing to do. So the most recent study from 2021 showed that Naltrexone IM and high-dose bupropion do help, and people are pretty excited about this. A fairly large trial, at least for methamphetamines, 400 folks, They used high-dose bupropion, and one of the authors of the study was talking about it, and he was thinking that probably one of the reasons the study was successful was because this was really the first study where people actually had high adherence to the bupropion, which they helped by paying patients for it to take the pills, not much. So we had really high adherence, and success was defined as 3 to 4 negative urine drug screens. Again, there's a lot of ways of looking at how people's lives can be affected, and just is there drugs in their body or not is not the greatest, but it's at least something. And essentially this showed that this combination was helpful. So 16% versus 3%. The number needed to treat is 9. This is pretty good for addiction interventions. These folks can be difficult to treat. These were all daily users. So definitely potentially helpful here. The naltrexone, I think if you don't have access to the IM naltrexone, hard to say how much that helped. Certainly for folks who have alcohol use, that may help. And if you got it, I think it's a great thing to do. You can also do a PO. So last, just the pearls. If there's no contraindications, certainly you can consider mirtazapine. I would start at 15 to 30. It's sometimes better tolerated, a little less sleepiness. And then the bupropion can be really useful. And again, you want to increase that up to 450 a day if people tolerate that. And look out for seizures, obviously. People are excited about that. We have a number of patients who have heard about that treatment. It's like, all right, let's use that. And obviously you want to treat all the other mental health conditions and addictions as well. So last thing, in our clinic, for these folks, if they're HIV positive, we try to do labs at least every 3 months. We try to treat the cardiovascular risk pretty aggressively because, again, when you look at the Framingham stuff, you're HIV positive, that's not included. A lot of these folks are smokers as well. So, it's a lot higher than you probably may think it is just based on the numbers and the blood pressure. And then, of course, this, STI screens, vaccinations, and naloxone. And, I think just the last thing, it's hard to do this. And so I think just stay kind, just be as patient as you can. People will get better or they won't. And, regardless, you can be there for them, and that's worth a lot. So I wanted to acknowledge all the folks who have really helped me make sense of this. And then we got the final acknowledgement there. So that's it.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.